Hello, my name is Tolonen and I'm from the Finnish Institute for Health and Welfare. I will be talking today about administered health registers, which are linked to the survey data and can those provide reliable information on health indicators in Finland. Health information is needed to support evidence-informed policy decisions. Different data sources for health information exist, from health surveys to different administrative registers. What is the quality and coverage of these different data sources needs to be evaluated, and which data source should be used to calculate different health indicators may vary by indicator. In Finland, the FinHealth 2017 survey, a national health examination survey, was conducted on the random sample of the adult population aged 18 plus and living on the mainland Finland. The sample size was 10,305 people and participation rates to the examination was 58%. The survey covered Finland throughout and 50 municipalities were examined, and survey was conducted in January and June 2017 by 5 teams traveling around the country. We have also several administrative data sources in Finland which can be used to obtain health information. There's the information on in- and outpatient visits to healthcare, including medical operations and prescribed medications. These include the date of care visits or visits to the hospital, as well as diagnosis using ICD-10 codes, and for outpatient visits also ICPC2 codes. For the medications, the anatomic therapeutic classification codes have been used, and for the medical procedures, Nordic classification of surgical procedures. We have linked the FinHealth survey data to these administrative health registers using the personal identification code, which is available both for surveys and the register data. The personal identification code is the unique identification number provided to everyone living permanently in Finland. For survey participants, we have the informed consent, written one, which also include informed consent for the register linkage. And for the medical records from the administrative data, we have obtained the permission from the register owners to perform the record linkage. From the medical records, we have obtained in- and outpatient visit information from the past 5 years backwards from the date of the health examination on the survey. What we have observed when we have looked the information on same individuals from survey data and register data is that for the diabetes, for example, the prevalence within the population is almost equal on these 2 data sources. So diabetes can be obtained quite reliably both by survey and register data. For heart diseases as well, we can see quite good correlation between 2 data sources. Obviously, the survey data provides a bit higher prevalence, but that may be that people report and how they grasp the idea of coronary heart disease may vary a bit from the diagnosed information provided in the register information. Also for the asthma, the correlation between survey and register information is very high and provide almost identical results at the population level. But when we come to the obesity, we can see the substantial difference between the survey information and what can be obtained from the registers. Survey information is based on the measured height and weight and calculated BMI from that. And then we can see that 26% of the population is obese. But when we look for the register information, only 3% of the population seems to be obese. And that comes to the fact that on the registers, height and weight is not systematically recorded to the patient records during the clinical visits. And only information we can obtain are the ICD codes and the medical surgery codes related to the obesity in the register data. Same goes for the hypertension. In surveys, we get substantially higher prevalence of population hypertension compared to the register information. Obviously, survey data may be a bit overestimating the true situation, as that's one-time measurement, which is not correlated directly with the clinical diagnosis of the hypertension, which requires sequence of measurements over time. The problem with the register information again is that blood pressure measurements are not systematically recorded to the patient records, which we can obtain from the in and outpatient data. And we have to rely only on the diagnosed hypertension, which is marked on that data. For the depression, again, surveys provide a bit higher prevalence of depressive symptoms than what we can obtain from the register data. But that may be due to the way it's asked. Are you experiencing a stressful situation or the mood changes? While on registers, we get the diagnosed cases. Obviously, each data source has its pros and cons. For the health surveys, we can diagnose or detect undiagnosed cases, for example, for the hypertension, and it covers both the private and occupational healthcare users as well. As in Finland, the in and outpatient register data doesn't at the moment include private healthcare users or the occupational healthcare centers. For the cons, we can see that many surveys are experiencing declining response rates, and non-response bias may affect our results. There's also self-reporting bias due to the awareness and recall of the incidences. And the health surveys are relatively expensive and time-consuming to conduct. On the other hand, for the administrative registers, the pros are that we can get clinically confirmed diagnosis for the diseases. Data accumulates automatically in more or less in real time without any additional costs. But as a cons, there's a differences in healthcare utilization in different population groups. Clinical practices for different conditions and in different organizations or different parts of the country may vary. There's a differences in patient record systems between the different hospitals and health centers, and data entry practices also may vary. And occasionally, over some diseases, we have a problem that medications used to treat them are unspecific for the disease, but they are something that are used more broadly for the many conditions. And through that, we cannot use the medication data to identify the cases. To conclude, administrative health registers can provide reliable information on chronic conditions which require regular medication and monitoring. Risk factors such as height and weight, and through that BMI and blood pressure, are not systematically measured and recorded in health services. Administrative registers cover only patients, while surveys cover entire population. So depending on the health outcomes, quality and coverage of the different data sources seems to vary. Thank you for your attention.